Welcome to the first episode of Addiction Doc, a podcast where we speak the simple truth about a much misrepresented and misunderstood field of medicine. Our host is Dr. Eric Troyer, a board-certified specialist in the field. If you or anyone you love is struggling with this terrible disease, this podcast is for you. Dr. Troyer is currently practicing in Landis, North Carolina, and can be reached at 704-855-2101. Or you can check out their website at troyermed.com. Let's step into this discussion and see what we can learn from Dr. Troyer himself.
Welcome to episode 1, officially, of Addiction Doc podcast. We're going to be discussing all aspects of addiction. Obviously it's a serious issue, so most of it will be serious, but there'll be some lighter-hearted moments as well. So I guess I think we probably just need to start from the very beginning.
That's a very good place to start.
When you read, you begin with ABC. With addiction, it starts with dopamine.
Dopamine. The culprit here just happens to be dopamine. Dopamine.
D-O-P-A-M-I-N-E. There are cells deep in your brain that contain the dopamine. And when they release that stuff, you feel really, really good. So you want to do the thing that releases the dopamine over and over again, no matter what the cost. D-O-P-A-M-I-N-E, dopamine.
Dopamine.
So, if you knew what we just did, you're probably our age.
You're probably really old.
But that little ditty actually captures a lot of what actually happens with addiction. So, I said start from the very beginning. There are two ways to go there. One is with who am I and why am I talking about addiction. Mm-hmm. The second, of course, would be with addiction itself. So I think we'll start with the former of those two and talk about who am I and why am I talking about addiction, what's my experience with addiction. And back in 2010, I was going through some personal issues in my life. Ended up living at my office and making a movie with Meatloaf and Ed Asner and some other people in it, which was a pretty neat experience. But now, financially, I was not in a very good place. And starting a new practice. And as most physicians out there can attest, whenever you start a new medical office, the first people who come see you are those people who want opiate prescriptions, along with a lot of other prescriptions as well, usually, but definitely opiate prescriptions. So that was probably 90% of who was coming to see me that first, year or so I was in practice. And so I thought, obviously these people aren't getting their pain treated well or they're addicted to opiates. I didn't know much about the addiction part of it at that point in time. So I said, I'll treat the pain, but I'll treat it right. So I started going to conferences, doing education, and started trying to do the best I could to treat pain. Made sure that we were trying to get at the cause of the pain, get at the underlying issues, and treat the underlying issues. Not just throwing medication at it, but doing things like physical therapy and braces and other non-opiate medications as well as that to treat the pain. So I was cruising along in that mode, and then one day, fateful day, a young lady came in and she said, I think I'm hooked on these pills. Could you please write me a prescription for Suboxone? I said, sure, what's Suboxone? I'd never heard of it before. So I went to my references and I looked up Suboxone and said, okay, I'll write you a prescription. Not realizing that I really couldn't. We'll talk about a lot about this later, a lot of regulations and restrictions around treating addiction. I could write a prescription for opiates for everybody in Rowan County, this whole area if I wanted to. But starting out, I could only treat 30 people for substance use.
Interesting.
Isn't it, though?
Mm-hmm. Makes you go,
Yeah, what's going on there? So that's But I realized after actually my future wife at the time told me that, hey, you realize you shouldn't do that. So I went and found out what I had to do to legitimately prescribe the Suboxone, which is to take an 8-hour course online that the government does, and then I was okay to treat my 30 people. So I did it, and I started doing a little bit more of that because once there's a big network out there. Once you start treating one person for something, word of mouth really spreads quickly that, okay, Troyer's treating addiction. So I started getting more and more patients in who were addicted not just to the prescription opiates, but back then to heroin. That was the big thing before fentanyl came along. And that's what tended to happen is the government cracked down on prescribing opiates. They went from probably 15 years ago to pain being the fifth vital sign. And I remember everybody remembers those little charts that had the faces on it and rate your pain 1 through 10.
I remember those, yeah.
You didn't go to any medical facility without, what's your pain level? How badly are you hurting today? What can we do for you? And actually almost pushing. In fact, I remember a time when medical board in North Carolina was implying or actually maybe even stating that if you didn't adequately treat people's pain, that they potentially would come after you.
So if you didn't give them
that they weren't satisfied
opiates,
and you got too many complaints from patients that you weren't properly treating their pain, that they would come after you.
Number 2 thing makes you go,
So
I'm not a conspiracy theorist.
Of course not. I'm really not either, except around addiction. And we'll kind of be elucidating that in this and future episodes. But so I started treating it more and more. And the second, first year you were limited to 30 people. After the first year, you could go up to 60, and then I think to a maximum of 125. After that, you had to jump through about 7 or 8 hoops in order to be able to prescribe buprenorphine and to be able to increase your number successively each year. And I jumped through those hoops. Some were reasonable, like taking insurance. Others were a little more esoteric and out there, but I jumped through the hoops and started doing it more and more, and actually realized that at one point I actually feel like this was kind of, of all the years in medicine, through family medicine, through the pain stuff, that this was what I enjoyed doing the most. I actually enjoyed, it was challenging, for sure.
Why? Why did you enjoy that the most?
I think it's my personality, but also watching people get their lives back, watching people get their kids back, watching people get their jobs back, watching people get their homes back.
It's like a country song
in reverse. Exactly. Exactly. I like that. So it's appealed more and more to me. So at the time, there was a board certification. It was kind of not truly recognized one, but it was a board certification done through the society, which is the American Society of Addiction Medicine. They're kind of the gurus and the leaders in this area, but they had their own little board that you could become board certified through. But about that time, I hate to say legitimate, but more legitimate board certification became available through the American Board of Preventive Medicine. There are big ones out there. There's family practice, internal medicine, surgery, the major board certifications that most board certified physicians go through to get their certification. And one of them is the American Board of Preventive Medicine. And for some reason, they're the ones who picked up addiction. It could have, in my mind, gone under family medicine or internal medicine or even psychiatry. But psychiatry actually does have their subspecialty in addiction. There are specialties like internal medicine, say, but then there are subspecialties underneath that like cardiology and nephrology and pulmonology, depending on what area they want to focus on. Now, those are all internal medicine board certified physicians, but they have their subcategorization in that particular area. Just like now, addiction is a subcategory, almost several others, under preventive medicine. So I had to proven that I'd treated so many different patients, what the outcomes were, have another physician review my records and send all of that in. Then I had to sit for an exam that showed that I knew a little bit about addiction, and fortunately I did well on that. And that got my board certification in addiction medicine. So I've maintained my board certification in family medicine, and I still do some of that, but honestly probably about 70+% of my practice right now is addiction medicine.
Now, at first, you were one of the very first people in the country to be board certified.
I took the exam the very first year that it was offered.
Okay.
Yeah. So.
And has that picked up?
I'm sure it's picked up some. There's still not a lot of people out there treating it. The government and insurance companies have tried to push family physicians and other primary care physicians into doing it. By making it a little less red tapey to get your ability to do that. At one point in time, you had to get a whole separate license number just to prescribe the buprenorphine products.
Now, I don't want to take you off from your pattern of what you want to speak to, but just a good segue and something that I think connects really well. Is before this was going on, methadone clinics were all over the place.
Yes.
Can you speak a little bit to that? Because I personally think from my experience, and by the way, I kind of do some counseling with Dr. Troyer. I provide pastoral counseling for some of the clients that prefer that, and he has some.
Well, you also do life.
I do life coaching, things like that. And you have some board not certified, but licensed professional counselors that do that, for which you bill. You don't bill for me, and but that's what I do. My name's Keith, by the way. But what we're what I'm trying to get accomplished, my experience has taught me that a lot of people look down on Suboxone because I think they relate it to methadone. And methadone's been around a long time before board certification, correct?
It has. Methadone's been around since I was starting in medicine, which is obviously a long time ago. I'm not going to admit how long that is, but a long time ago. Yeah. And I always thought of that as a, yeah, you can have that. Just keep all that away from me. Treating addiction in general, I have no interest in that. And at the time, I didn't. I was like probably 80% of the country, and it's just drug addicts, and they made their decision and made their bed, and now they'll lie in it, kind of thing. And the more I've come to learn about addiction, which we'll get into momentarily, the more I realized that they didn't necessarily make that decision. That they were born with that decision somewhat made for them. Just like diabetics were born with that decision made for them. People who get cancer, depending on how they get it, had that decision made for them. But yeah, the methadone aspect, it's all we had. The concept there is, I guess we'll get in a little bit to the receptors, and we'll get the definition here in a little bit. But there are millions of little mouths, if you will, called receptors. They're at the end of our little nerve cells in our brain, called opioid receptors, mu receptors, whatever you want to call them. And they're in our body for a reason. Our bodies actually make opioids. They're called endorphins. They're called endorphins and enkephalins. So when we exercise or something good happens to us, they get released. And poof, out they go. They circulate. They come to the brain. They hit that receptor. They push it down to here, and we feel good. The pills push it down to here, the opioids, and the injectables, push it down to the floor whenever they hit the receptor, as far as how strong and they hit the receptor and how much chemicals get released as a result of them hitting that receptor. Buprenorphine, Suboxone, is what's called a partial agonist. When it hits the receptor, it pushes it back like the natural ones. But mostly it's just sitting on that receptor, which, as we'll discuss later, is an important thing. The methadone hits the receptor, pushes it down just like every other opiate out there, including...
and pushing it down meaning the sensation?
The sensation, the effect on the body, the release of the chemicals that then go on and do their thing. So methadone is what's called a full agonist. Buprenorphine is what's called a partial agonist. which we'll get into without going in depth. In preparing for this podcast, we did listen to a podcast or two on addiction, and they're talking about downregulation of postsynaptic inhibitory neurons with an inhibitory output. Blah, 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 blah. And I just that's not what I want this podcast to be. I want this podcast to actually be more relatable, more understandable, more for everybody. And we're focusing not only people who are addicted, but actually the family members as well. Because for every one person who's addicted, there are up to a dozen other people affected by that addiction. So that's kind of where we're focusing now. But back to methadone. At the time, it's all we had. And the concept there is the slower something comes into your body, the longer it stays in your body, and the slower it comes out of your body, the less likely it is to become addictive. The more addictive things like nicotine, say, you smoke it, level goes up to here, goes down to there. If that happens that quickly and that in and out, a lot of times they think that's more addictive. So the concept with methadone is it's very long acting. That it is. Unfortunately, it's got a lot of other ill potential effects, including on the heart. Everybody on methadone is supposed to have an EKG done every year because of the negative impact it can have on the heart.
Oh.
And it's either 5 to 10 times more likely that you die of an unintentional overdose if you mix it with anything else. And
You're kidding.
No, it accounts for like 2% of prescriptions, but 10% of overdose deaths when mixed, unintentional overdose deaths when mixed with other agents such as a benzo or alcohol or what have you. So it's a dangerous drug, but for the longest time, it's all we had. And the only people who were at that time who were probably interested in treating addiction for whatever motivation there might have been. I'm not going to necessarily attribute it to altruism or doing what's people's best interest. I think there might be some more darker motivations, including the ultimate one, which is of course money, is methadone clinics. And they were, handing out the methadone. If you did good, you got to get your take home, so you didn't have to come every morning. Otherwise, you had to be there every morning to get your dose to get you through the day. Our thing about methadone, though, is it's a full guy agonist. So it hits, it takes maybe an hour or so, but during that it hits, and during that time when it's active, you've got your energy going on, just like with any kind of opiate. But then after a couple hours, this is how you tell somebody who's on methadone is they're just nodding out. Not a big fan. It was what we had when we had. That's all we had. That's all we had. But now that there's buprenorphine out there, I don't know that I see a whole lot of place in the treatment of addiction with methadone.
It's kind of like, I think substance abuse, medically assisted substance abuse treatment has a bad rap because of all those years of methadone.
Right.
And now when you come in, you're really monitoring the chemicals in their system. We're doing counseling with them, working through it. Ultimately, the goal eventually is, if possible, to even get them off that and get them back to just not being dependent on anything.
Yeah.
Ultimately, it doesn't always happen.
Well, the relapse rate is 90%.
It's 90%.
90%. Because they're born with the gene, and if you're born with the lupus gene, you've got the lupus gene. It's not going to go away.
Okay.
You can treat your lupus and keep it in remission, or whatever illness it happens to be, hypertension, whatever. You can treat it. You can keep it in remission as long as you're doing both lifestyle and medication. You can't do one or the other. You need to do both. Just like with this, it needs to be both lifestyle, counseling, and medication.
But a lot of folks kind of look at medically assisted substance abuse treatment. They look at it as trading one drug for another.
Yeah.
And that is just not true when it comes to Suboxone.
I have the perfect analogy for that, and I might need to borrow your hand. Is that what I'm going to use?
We can use that. I can use this. Yeah.
All right. So, let's say that the receptors for touch on the back of your hand are the receptors in your brain for opiates. This is an opiate. So there we go with the opiate hitting those receptors, and you're feeling it.
Mm-hmm.
This is buprenorphine. Is that the same thing?
No.
No. It's not, because what it does is it sits on the receptors. And now, in fact, if you did try to stimulate an opiate into the system, do you feel that?
No.
You're not going to get any effect because the receptors are blocked. So there's no way for the opiate. So you're not trading one thing for another. That's
the difference between a full antagonist and a partial antagonist.
Full agonist, yeah, and a partial
agonist.
Yeah.
Okay.
Yeah. So yeah, but let's backtrack now and quickly do, well, not quickly probably, but do the definition for addiction, which I'm going to have to read, but there are going to be multiple breaks in it. All right, addiction is, and this comes from the American Society of Addiction Medicine, a treatable. So we'll pause there. Treatable. Does that mean that there's a choice involved? People ask me a lot, is this a choice or is it a disease? And the answer is yes. It's a disease. Again, studies, genetic studies, twin studies, adoption studies have all shown that you inherit it to a certain extent, to a very actually large extent. So it is a disease. Where does the choice come in then? The choice comes in with, do you treat it or not? Or do you
Let's say that again. My ears are a little bit.
The choice comes in is, do you treat it or not?
Okay.
Or do you continue in your disease state? Because there is good treatment now. Back when methadone was the only thing, that could be argued either way. But now that buprenorphine and another injection, Vivitrol, naltrexone, have come along, there is good treatment. So that's where the choice comes in, is do you continue to lose everything, or do you run that country song in reverse and start getting stuff back? Because right now, yes, the powers that be a lot of times are making it more difficult, but every new patient who comes in, I always run the numbers with them. Say, here's how much you've been spending on your drug. Here's how much it costs, even if you don't have insurance, to come see me and buy your medication. And it's like a factor of 5 more expensive to continue doing the drug.
5 times.
5 times more expensive. But that's part of the addiction, which we'll get more into the definition here, is why a lot of times that decision's not made. They want to kind of continue on with what they're doing.
Self-treating or self-medicating.
I know some of it is, but a lot of it's just, fear of something different, fear of change, fear it won't work for me, lack of motivation to just change what you're doing because you're just so tied up in it. I always tell people, if you can just look at your life like you're looking at a TV show, if you can have that ability to just take yourself out of your position and what you're going through at that moment in time, it's just good life advice in general. And sit in the chair here and watch your TV show and you see what you're doing. You would be screaming at that person if it was somebody else saying, "What are you doing? Don't do that." It's like a horror movie. Don't open that door. Always making the wrong decision. But some people just aren't able to do that and just kind of are so tied up in their lives that their change and the thought of change just really either doesn't occur to them or is scary. It's just really, really scary. So, treatable, chronic. That means, again, lifelong. This is not something you get like a sinus infection. Take your antibiotic and get over. You were born with the gene. I've had people, unfortunately, relapse years and years and years after being clean. And that's a reason. The relapse rate is 90% if you come off the medication. So, it is chronic. Medical disease. It's not a character weakness. It's not a flaw in their sense of right and wrong. It's not this.
Which is
a medical disease.
In that the way we treat people in society,
yes,
that there's a character flaw with them.
Yeah. And that, you just don't do it.
That's like telling somebody with anorexia, they just need to eat a sandwich.
Yeah. Yeah, just don't do it. You got that choice. You got that choice. Yes and no. Mostly no. Yes, if you're getting medical treatment and psychological assistance and all that. Yes. I know enough and I've seen enough success to know that yes, this is very, go back to treatable medical condition. But it is a medical condition. It's not what society Because I remember in church, let's reach out to the worst people you can think of, let's get to the drug addicts, the murderers, the rapists, and the drug addicts. Let's lump them all together. Even though most things that, if any of the drug addicts are actually guilty of as far as crime-wise is larceny just to support their habit, or other ways of things that they might be selling just to support their habit. So medical condition, medical disease, and I love there to draw an analogy, I touched on it previously, between diabetes and substance use disorder. They both have a big genetic component, but they both have, definitely an environmental component as well. Especially type 2 diabetes. Type 1 diabetes, ones the kids get, are definitely pretty much all genetic. With the type 2, it usually, ties into weight and diet as well. So, you're born with the genes. Some people can weigh 700 pounds and not have diabetes, and I've seen it. But most people, or a lot of people, once they hit a certain weight, then their sugar starts going up. So you treat them with medication to get their sugar down, but at the same time, you change lifestyle. You try to modify the diet and get them to do that. Same thing with the opioid use. They've got this chemical imbalance or receptor imbalance as far as what happens when the opioids hit the receptors in the brain. That's just different than other people. I mean, some people, alcohol. Some people can have their drink on New Year's Eve and not want another one until the next New Year's Eve. Some people, once they have that first drink, it's over. Pornography. Some people can, watch it one or two times or whatever. Some people, once they get started, it's over.
Can't let it go.
And opiates. Some people, get that first pain pill either at 16 from their buddy or at 28 from their doctor after their minor procedure or what have you, and they take it and it's over. Other people, they take their 3 days worth of medicine and, they're good till next time they have another procedure or need for an opiate. And again, that's just the variability. But pretty much everybody I come in, I tell them that taking this medicine, dissolving the strip or this pill or what have you, is the easiest thing you're going to do in this entire process. The most difficult part is getting people out of your life, changing your phone number, getting off social media, except for this podcast, of course, and doing the work that's involved. As far as my position in this, I'd like to think of myself as a coach. I know what plays we need to run to get a first down and into the end zone. I'm not the one out there getting muddy and beat up and scuffed, though. That's the people who I'm treating. And I try to prepare them not only with the medication to play, but also with the skills that they need to run that play, which is going to be the counseling. It's going to be learning new coping techniques. What do I do when the dog dies or when I stub my toe? Do I run and go get some pills or shots or what have you? Or do I, get a new puppy and put a Band-Aid on my toe?
It's kind of like, how do I handle the thoughts? How do I handle the emotions?
Yes.
How do I know the difference between the thoughts and the emotions?
Right.
It's kind of, I think it's a lot about emotional intelligence. I think it's a lot about life coaching and, just learning to how you reframe things in your life. I think getting, once you start that path, once you start getting your choice back, your free will, if you will, it's about what are you going to do with those decisions, and I'm not talking about decisions to use or not to use. I'm talking about decisions about who's going to be in your life.
Right. That's a big one.
Yeah.
I've the past few weeks, I've gone through figuring out the difference between the 80% of my patients who are doing well and the 20% who are not doing so well. And after asking the patients the question, I came up with the answer. The 80% group has to get 10 people out of their lives. The 20% has to get 10 people out of their lives. The 80% wants it badly enough to get 10 people out of their lives. The 20% get 8 people out of their lives, pat themselves on the back for doing that, and keep using with the other two. It's so much about who you put around it, who you're with, and who else is in your life. Not only with this, but with all sorts of things. But
I highly agree.
Especially with this, as far as who you choose, again, where the choice comes in, to have in your life, and who you choose to to get rid of, because that's going to be key as far as your success. But back to the diabetes thing, you have to do both medication and lifestyle changes. Otherwise, you're not going to make it. Diabetic takes his medicine, eats what he wants, sugar's going to be high. Eats perfectly, but doesn't take his medication, sugar's going to be high. Same thing with the does both, sugar's going to be okay. Same thing with this. Take the buprenorphine, ignore the psychological aspect, the counseling, the lifestyle changes after coping techniques. You're not going to make it. Do all of the other stuff perfectly, but not take the medication. Unfortunately, you're probably not going to make it. Some people do. For some people, that's all they need, and those are people who probably don't have the gene to start with. But but most of the time, it does take both. People's involving complex interactions among brain circuits.
Can you say that again? I'm sorry.
Okay. It's a chronic medical condition involving complex interactions between brain circuits, genetics, we've already talked about, and the environment. There's no doubt that people who have grown up in an abusive environment, not just substance abusive, but abusive, physically abusive, emotionally abusive, sexually abusive, any abusive environment are more likely to use substances.
Oh, really? Yeah. Interesting.
Lots of studies have shown that. So that's where the environment type comes in. And an individual's life experiences. So same thing there. People with addiction use substances or engage in behaviors. So again, there are behavioral addictions as well. Gambling is the only one that's formally recognized, but there are obviously others, including, in my opinion, people. I firmly believe a person can become addicted to another person.
Oh yeah, I believe that for sure.
All right. Engage. Let's see. People with addictive. So engage in behaviors that become compulsive, which means resulting from or relating to an irresistible urge. That's when you see people with OCD, obsessive compulsive disease. The O is the obsessions. Those are the thoughts. The compulsions are the people you see walk in and out of a room 100 times because they didn't get it right, or take a shower 23 hours a day because they don't feel clean. Those are the compulsions, just physical things that you do, such as taking the drug that your mind just isn't seem to be really able to control. And I think that there's some underlying anxiety with all of that, especially one that is against one's conscious wishes. So a lot of times people want, they don't want this. They want to be clean. They want to be like everybody else. They want to be like they used to be. And often continue despite harmful consequences. And that's probably one of the definitions that I go by for any thing. And that's why, again, I believe relationships can be that way. Is that's kind of one of the hallmarks, and all I try to point out to the patients is, look at the effect that this is having on you, on your finances, on your relationships, on everything. This is, it's doing harm. It's not just, but it's actually doing harm. And the thing about the addiction process is it does happen, as our little ditty said at the beginning, deep inside your brain, some of the most basic areas of your brain. There's the basal ganglia, which are responsible for reward and making something feel good, and that imprints it on your brain. So, okay, this is good. I need to you need to remember this so that you can do this again, because this feels good. So the chemical that helps do that is dopamine. Making something feel good, and then working on the memory part of your brain says, okay, remember this. So like the first time you get high, remember this. And even though each time you do it, you feel less and less, and you don't never get that feeling again like the very first time, as Foreigner would say.
As Foreigner would say.
feels like the first time. Like it never will again. But that's the part of it. There's the amygdala, which actually is more in the withdrawal part of things. It kind of controls the symptoms and negative feelings you get when you're coming off with a chemical. So again, it's just your body's way of reinforcing the deep part of your brain, saying, okay, that felt good. Let's not go without it. If you go without it, we're going to make you feel bad. We're going to make you sweat and shake and all this other stuff. So let's not do that. Let's not go without it too long, or you're not going to feel real good. You're going to want to get it again. In fact, I don't know. It's different for different people as far as how long, but invariably, most people end up getting to the point with their addiction where they're just using not to feel bad, to keep the amygdala quiet, rather than to get a whole lot out of it. I mean, the basal ganglia have already burned out more or less by that point in time. So yeah, you might be getting a little bit out of it, but you're just trying to avoid that withdrawal. And that's such a motivator for people who I see come in is, I don't want to get sick. And they fear that so badly. And if we're starting up on the medication, a lot of times, pretty much every time, you have to let them start to get in withdrawal. Otherwise, you're going to kick them into withdrawal. So that's the scariest part for them is having that little bit of withdrawal right there at the beginning before we can start the medication.
Mind if I ask a question at that point? Kind of from a counseling standpoint. Mm-hmm. I've done a lot of study in emotional intelligence and things, and the amygdala is a big part of that. And what we learn in emotional intelligence is sometimes we get what's called an emotional hijacking. Mm-hmm. And the amygdala tends to override the logical centers of our brain.
Yes.
And it causes us to react in a split second. And it's kind of like a survival mechanism inside the brain. Mm-hmm. That sends a signal down to the kidneys, and the kidneys produce the adrenaline that equip us for one episodic, dose of adrenaline for one episode of fight or flight, mm-hmm. right? Is there in the withdrawal, or actually in the I'm going to use? Because I hear a lot of my a lot of the patients, when I'm talking to them, they'll say when they decide they want to use the drug, they'll go and they'll get the drug. Mm-hmm. Before they get home, they already feel better. Just having it in their hand, yes. They already feel better. And they haven't injected it. They haven't done whatever they do to bring it into their body. That is an amygdala. That is an emotional hijacking and a release of adrenaline.
It comes back to the endorphins and Kaplans too. I'm sure that again something good just happened. They got their
they
score.
Got their hit.
So or they haven't gotten the hit yet, but they're about to. So the endorphins and the Kaplans also get released because something good just happened. They were able to find it for today. Tomorrow's a whole new battle, a whole new story.
Which tells me there's psychology involved in this
absolutely.
Whole thing.
Oh,
and it is huge. And if you could get people to readjust, maybe kind of like cognitive behavioral type therapy, mm-hmm. to kind of form new neural pathways in their logical processes, to find that adrenaline, find those chemicals, those natural chemicals, mm-hmm. before they start injecting the synthetic chemicals. Yeah. If we can get them to people, and that's where it kind of comes into choice a little bit. Mm-hmm. I don't want to, but if we can get them to choose to search after natural endorphins, right? I'm speaking maybe out of school here.
Well, I mean, if they're able to, I will recommend getting into an exercise program. Mm-hmm. Just because, again, that natural high is real. I mean, this comes from our natural endorphins being released and hitting the receptors. And that's the problem too, though, is after a while of using, you've hit these pleasure chemicals so many times that it takes a lot, if anything possible, to make you feel good, to make you happy, to make you, other than, of course, the drug itself. So that's the other, where it tends to lead to depression or depressive type feelings. A lot of times you wonder, well, should I go ahead and treat the depression at the same time? And a lot of times the answer is yes. A lot of times it was pre-existing, which is why some people are using the medication the first time to self-medicate depression or anxiety or some sort of other PSD is a lot. I see that one.
PSD or PTSD?
PTSD.
PTSD, okay.
Yeah, left out the T there.
Yeah. Just put a little apostrophe in there.
Yeah, there we go. Apostrophate it. Yeah, that's but overall, it's probably best not to treat somebody for a condition until they're off the drugs, because at that point in time, because a lot of times the drugs are interfering and affecting the emotions that we have, both ways, the emotions affecting the drug affecting the emotions. But the third part of the brain that's affected is the prefrontal cortex.
Cortex. Oh, are those the lobes?
Those are right up here in the front part of the brain. They are one of the last ones to mature. They don't mature until you're about 25 years old, which is why younger people are so much more vulnerable to the effects of drugs.
Don't get me started. I love young people. I have a couple.
Yeah.
Right.
But yeah, like with marijuana, it literally lowers the IQ 5 points. The studies have shown that it lowers your IQ 5 points.
And
Adults,
that's forever?
Well, if you're under 25, we don't know. I mean, their IQ's so low anyway that it's hard to tell. Sorry, just kidding. But with people whose prefrontal cortex has stopped developing, yes, it does come back when you stop using. The prefrontal cortex affects decisions and assigning value to things, among other things, but those are the two biggies. So your decisions stop going about, what can I do to take care of the kids, and should I be looking for a different job, and, what can I do for my neighbor who's having problems or what have you. And they start focusing on how am I going to get this drug? How am I going to get this drug? And how am I going to get, the drug? And then you assign value to things. My kids get a value of 10. Well, okay, today they're going to get like a 6 because I got to leave them and I got to go get this other stuff. And basically every other thing in your life, the value goes down on, and your drug of choice.
And your choices. Yeah.
That's where the decision making process comes in, and the value assigning. So it all kind of ties in too by hitting that part of your brain. Well, it essentially hijacks your brain into making drugs then the most important thing in your life. First thing you think about in the morning, last thing you think about at night, and therefore making it more and more difficult for people to make that decision to make a change, to get off of them.
So, earlier in the conversation we were talking about it's not a choice, right? But there is choice involved.
There is choice involved, absolutely.
There's choice involved.
Again, choice to whether or not you get treatment or not. Because fortunately there
But that's not the only choice.
That's not the only choice.
Yes.
But yeah, there is choice involved. And then again, focusing on the family members. What can you do to help that person make that change, make that choice? Mm-hmm. That's tough. I started writing a book a few years back about that exact thing. Trying to focus on the effect that this has on the family member, and what can you do. I started off with in the preamble with, I love science fiction, have since I was a kid. And in every science fiction television show or book I've ever experienced, there's always at least one episode that involves an alien being coming in and hijacking the brain of one of the main characters. But sometimes the main character's aware that is there and they're still in there somewhere. Sometimes they're not. Sometimes they're just completely taken over, and at the end of it all, they don't remember anything. They're no longer in control of what they're doing. And then eventually, the rest of the main characters figure it out and say, okay, what's going on here? They're not acting like themselves, or something different. And that's what you got. The preamble is there's definitely something about they look the same. They're wearing the same clothes, got the same hair and everything else. But there's definitely something about
different behavior,
their soul and their eyes, even their eyes, and just when you look at them, just the energy they put off. It's just different, and so they can tell. These people in these stories can tell, and eventually, with the help of their family and their friends and whoever else needs to be helping them, they expel this foreign invader, and everything goes back to life as normal, and move on to the next episode. And that's why it's called science fiction, because in the real world, Every 9 minutes, somebody dies of an unintentional overdose. Families are torn apart. Children are abused. Spouses are neglected. Families are torn apart. So, that's again why it's called fiction. So what can family members do to help with this process? It's a complicated question that I'll probably touch more on the next episode because we're running low on time, and I'm going to spend a good bit more time with that. And with that, I'll go ahead and move on to the weekly update, something I'm going to do every episode, based on what I'm seeing on the drug screen results that I'm getting back. Most recent thing is ecstasy. After not seeing it for years and years and years, I've had
decade at least,
2 positive tests in the last few weeks. So be careful out there because the first one ended up in the hospital. It's not a benign drug. So be careful what you're getting. I think, actually, I don't know if either one of them was aware of what they were getting. But I see that all the time too. I surprise somebody probably every day.
When they find out that there's something in their bloodstream.
Yeah. Most recently it's been meth. Well, fentanyl. I mean, probably those two are about even. Maybe fentanyl a little bit higher as far as there was fentanyl in my marijuana. And yep, there sure was. And in fact, I think, probably 6 months ago or so, 4 people in Rowan County here died just smoking their joint because it was laced with fentanyl. So yeah, it happens. Drug dealers, just can't trust them. Who'd have thought?
Who'd have thought?
Who'd have thought? So that's my update on that. As far as how these podcasts are going to run, my goal is to, if it's not already there, very soon, to have a place on the website that you can go to and upload your questions. Because I'd love to have some interaction with those of you out there watching us. And interviews. I probably got a couple more episodes just with me and the Keithers. As far as touching on the basics of addiction, I'm going to go through the different ones a little bit more in depth next time. And then of course the update of the week with each episode as well. So I look forward to getting feedback. Look forward to questions. And interviews. I'm going to try to get some psychologists, maybe a pharmacist. And I've had quite a few, once I found out I was doing the podcast, quite a few patients who are interested in telling their stories, which I think a lot of times, even with the counseling, one of my questions of the week was, what topic of counseling has been most beneficial in your recovery process? 80% of it is probably, there wasn't a topic. It's just getting together with people who are in the same boat that I'm in, and being able to see I'm not the only one out there doing this and going through this. Mm-hmm. That's the answer I got to that. So it's not necessarily the topic; it's just the process. That seems to be helpful. Yeah.
For sure. Yeah, I think before we kind of wrap it up, I think I'd like to point out that you've got some patients who want to share their story, and I love that because I've spoken with a lot of the patients, and they've got some phenomenal stories. And those will be very entertaining. These people, they're beautiful human beings, and I just love them to death. I've been, I don't even know now, maybe 5 or 6 years I've been doing this coaching with them, and I have grown to just love them desperately. I just think they're amazing. They're friends of mine, and I just wanted to preface, or just wanted to kind of speak to that. These people want to still tell their stories. Mm-hmm. It's not like if you decide if you're struggling with addiction and you want to come to see Dr. Troyer at Troyer Medical and you want to talk about your issue, that's totally confidential. You're never going to be on.
I never approach anybody about doing an interview,
but they want to. They want to tell their stories, and they're proud of where they've come from, and they're proud of everything that's happening. Yeah, rightly so. So when you hear these stories, know that this is something that they want to share. Yeah. And and I've always found that people walk in a little trepidatiously when they come into counseling. The first thing they do is they're kind of like, "Well, I'm not a heroin addict. I'm not out here on the street corner buying drugs." And quickly they find out that, yeah, about 85-90% of the people in the room aren't either. Right? And it is, everybody has a different story. Everybody has a different path. And there are so many professionals out there, people in all kinds of careers. This addiction does not discriminate. And there are some phenomenally successful people that wrestle with this. So if that's you, I strongly recommend you get in contact with Dr. Troyer. And I think you'll find a lot of help there.
Well, thank you. And yes, the contact information will be at the end of the podcast. So thanks for your attention and your time and your listening. And if you got something out of this and you know somebody else who might be going through something similar, feel free to pass the information along. And on that note, until next time.
Peace out.